Good morning, everyone, and I think it's already 8, and we'll begin the course. And I'm hopeful that my other co-panelists will join me in due course of time. I'm Dr. Prashant Garg, and I'm currently the chairman at LV Prasad Eye Institute. Welcome to this instruction course, which is titled Corneal Infections, When to Suspect Unusual Pathogens. I do not have any financial disclosures to make. I think we are all familiar with that the corneal infections occur much more often in low and mid-income countries as compared to most developed world. And it is estimated that probably the incidence is about 8 to 10 times higher than what is being reported from most of the Western world. And I think it is because of this high incidence of corneal infection that corneal ulceration at the beginning of this century was identified as a silent epidemic. And more recently, how can that be? This is my laptop.
1 second.
We just checked also.
Yeah.
Okay. I'm sorry. So corneal infections occur much more often in the low and mid-income countries as compared to developed world, and therefore it is recognized as a silent epidemic. In addition, more recently, infectious corneal ulceration was proposed to be labeled as a neglected tropical disease status. Most of the time, corneal infections begin as simple corneal abrasions or are predisposed by contact lens wear. And from these simple events, they progress to frank ulceration and infiltration of cornea. But if you diagnose and treat these cases promptly, not only the infection resolves, but there is a lot of preservation of visual acuity. On the other hand, if we do not treat these cases promptly, they can lead to progressive worsening of the infiltrate, corneal perforation, and even loss of the eye. And therefore, timely institution of an appropriate antimicrobial therapy is very, very essential. The question that always remains is, can we treat all of these cases using a standard combination of drugs or a standard therapy? The answer is obviously no, because all of these cases are caused by a wide variety of microorganisms, which not only include bacteria, but also include fungi, parasite, and microsporidia or some of the other difficult organisms. And therefore, it is very important that we diagnose these cases using an appropriate laboratory method or in vivo confocal microscopy. What I'll do is that I'll try to cover this talk of laboratory diagnosis, which was supposed to be given by my co-instructor, Dr. Savitri Sharma. She somehow was not able to come to this meeting. And therefore, let me give you an overview of what are the different diagnostic strategies that we use in cases of ulcerative keratitis, discuss with you pros and cons of each of those diagnostic modality, and suggest how to make best use of each of those available options. I think if you look at a vast majority of the cases that come to us at a tertiary eye care center, these are treated empirically. And many a time, clinicians argue, no, I was having a definitive idea about what is the organism. It looked like fungal, and therefore I have started antifungal therapy. But since I need to provide coverage for concomitant bacterial infection, I have also added antibacterial therapy, and many a time even antivirals are added. So this cocktail therapy is a very common way that patients are treated at a community level. Now, how good is this empirical method of diagnosing etiological agent? Yes, there are certain characteristic clinical signs that will help you arrive at a differential diagnosis. The advantages of this kind of methodology for picking up etiological diagnosis is there is no laboratory support needed, there are no additional costs if you are an experienced clinician and probably have a lot of experience in treating cases of corneal infection. And based on the epidemiology of that region, you may be correct and you will say, I am getting a high cure rate in my cases even without treating these patients empirically. But you must remember that there are no exclusive characteristic signs. There is considerable overlap of clinical features between different organisms. Number two, this kind of methodology of making etiological diagnosis is particularly challenging in geographical areas where fungal infections are as prevalent as bacterial infection, where the rare corneal infections are also common, and where the problem of antibiotic resistance is constantly increasing. In addition, if you give a combination of therapy, drug toxicity becomes another important region for non-resolving keratitis. I'll give you an example of this patient who was treated for close to 6 weeks before this patient came to us, was on multiple antibiotic as well as combination with antifungal agent. We did corneal scraping was negative, and what we did was that we stopped all the antimicrobial agents and started this patient on cycloplegics and topical lubricating drop. This was the response within first 10 days, and that made us sure that we are dealing with a keratitis medicamentosa. And then finally, this patient progressed to complete resolution in 4 weeks with significant preservation of visual acuity. There are publications that have looked at clinicians' ability to distinguish between bacterial and fungal keratitis, and they found that other than feathery hyphate edges, there were no other clinical signs that were not overlapping between bacterial and fungal infections. And therefore, you will find that the literature strongly advocates that ophthalmologists must do microbiology workup in order to identify the causative organism and start treatment based on the microscopy and culture and sensitivity results. So in our view, empirical therapy, if at all being practiced, should be used only for small ulcers. Ulcers which are 2 millimeter or so have less risk of threatening the visual axis, and where the clinical signs of fungal and acanthamoeba are missing. In those cases, you can start therapy only with antibiotic and call these patients at 48 to 72 hours to understand what is a response to therapy in these patients. The patients which are larger than 2 millimeter or are having infiltrate encroaching on the central cornea or have significant thinning must undergo a detailed microbiology workup, and the treatment should be based on the microbiology workup. If you do not have the facility of microbiology or managing these cases, it is better to refer them to higher centers sooner than later. So what is a classical microbiology protocol that we follow? We use the corneal scraping either using the 15 number surgical blade. You can use even Kimura as a spatula or even the calcium alginate swab. The sample so collected is smeared on pre-sterilized clean glass slides for gram stain, Giemsa stain, and is also used for potassium hydroxide chalcofluor white. It is directly inoculated on culture media that facilitate growth of bacteria, fungi, as well as parasite. And wherever the facility for PCR is available, you can also use phosphate buffer saline to preserve the sample for DNA extraction and subsequent PCR. The advantage of this kind of microbiology workup is you can visualize organism directly on microscopy and immediately start treatment based on the microscopic examination. The organisms will grow on the culture plate and you can identify these organisms based on biochemical reaction. You can even perform antibiotic susceptibility test, and this methodology also help you identify some of the rare organisms which we will be talking in today's course. However, you have to realize as a microbiologist, as a ophthalmologist, many of us do not have very well equipped laboratory. And even if you have the laboratory, you will require help of a trained microbiologist in order to process all of these samples. There are additional costs, and corneal infections occur in mostly low socioeconomic strata, may not be able to afford. And then there are issues around the sensitivity and specificity. A negative microbiology does not mean there are no organisms. Whereas there are certain organisms, if they are present in the microscopy, you are definitively sure that your case is caused by a particular etiological agent. So what can you do if you do not have microbiology laboratory support? I think a simple bimicroscope with potassium hydroxide can help you distinguish fungal from non-fungal infections and may help you start appropriate therapy. In addition, what we found recently is that trypan blue-based staining method delineate fungal filament as well as parasite much more clearly, and therefore will enhance your ability to pick up these organisms. The second method that we use commonly to identify causative organisms is corneal biopsy, particularly in patients where the infiltrates are deep and corneal scraping is unlikely to result in any. In these cases, you can raise a flap and then take a deeper scraping or even remove a section of the tissue, which will help you identify the causative microorganism. Here the advantages are that you have a larger tissue sample which can be processed not just for microbiology but also gives you histopathology. It also helps identify organisms which are either slow in growth or are difficult to grow, particularly the Mycobacterium tuberculosis. And at times it helps debulking of the tissue and resolution of the infiltrate. On the other hand, it is an invasive procedure. You are removing a tissue and therefore there will be resultant scarring, irregular astigmatism. And here again you have variable positivity rate. It is not that the sample that you have taken show you the microorganisms. In our at our center, the first diagnosis of microsporidial stromal keratitis was made because we did biopsy from this patient who was having central infiltrate, and repeated corneal scraping were not able to give us a diagnosis. So we did a penetrating keratoplasty, excised tissue was examined microscopically, and we found. Similarly, in this patient, in the interface following post-LASIK infection, the flap was amputated because it was already necrotic, and this flap showed multiple acid-fast bacilli, and the diagnosis of atypical mycobacteria was made. Confocal microscopy is another method of making diagnosis. It is rapid, repeatable, non-invasive examination technique and gives you in-clinic diagnosis. The pros for confocal microscopy are that it is a rapid in-clinic test, give you prompt treatment initiation, help assess the depth of the infection, and also can be repeated to assess the response to treatment. However, you have to remember that except for fungal and acanthamoeba keratitis, the sensitivity of this test is relatively low. It also requires patients' cooperation to pick up good images, and the interpretations are usually dependent upon the person who is performing test and its experience. Further, the tool is more expensive and not available to all. So for us, the indication for confocal microscopy are where the microbiology is negative and there is a strong suspicion of fungal and acanthamoeba keratitis, where the infiltrates are deep-seated, and we also use this modality to monitor treatment response at our center. A word about molecular diagnosis. They are becoming more and more popular. The samples are subjected to DNA extraction, which is then processed either through standard or conventional PCR or through RT-PCR in order to identify the genes which are very characteristic with particular organism. Now there are wide variety of diagnostic tests which are based on molecular methods. Each of these tests have their pros and cons. The most important thing is that while they are allowing you to pick up microorganism within 4 to 8 hours, they also involve additional cost, and many of the centers may not have possibility of these machines being available, and therefore these tests have still not become very popular. But in the times to come, I'm sure these tests availability is improving as well as the cost is reducing, and they are going to take a bigger role as far as diagnostic microbiology is concerned. For us, this test has been very useful. While doing fungal PCR for organisms which we could not identify because of the lack of sporulation, we did DNA extraction and looked at, and we were able to identify Pythium insidiosum because of the molecular diagnostic test, and then establish a methodology to identify that using routine microbiology workup. So in summary, there are numerous new diagnostic tools that are under development. However, as of today, conventional microbiology continues to be a gold standard, and the future for rapid identification of microorganism remains bright, particularly when we are talking about rare organisms. And in today's instruction course, the molecular methods are going to be playing an important role. With that, I'll like to end the first part of this course, which is more around the diagnostic microbiology. And I'd like to invite if there are any questions before I switch over to my talk on antimicrobial resistance. Amrita, you can set up your talk on that side. Next, you can take that. Are there any questions? Yeah. I'm not able to hear you.
I was just asking how much is your culture result positivity rate?
Yeah, so the culture positivity rate is roughly about 60%. And I think and that too is primarily because we have a lot of fungal infection. But if you talk about pure bacterial infection, it is even lower than that.
And would your microbiologist tell you for example, this is the general, to what extent will they go further? Do they test to be very specific to the actual organism?
Yes, they are able to, because they are using the YTEC method, which is able to give you using a chain of what you call as a biochemical reaction, you can narrow down to certain level. And we also have started doing PCR for identification, which is helping us distinguish.
Also the PCR, they usually tell us, you can go and give 16S or 18S, pretty much that's it. And to actually have more diagnostic ability, then it will be costing so much more.
Yes, so it is sparingly used. It is not that for example, currently we are running a project on fungal pathogens. And we are not just saying it is Fusarium or Aspergillus. They are able to give us more specific diagnosis to the species level.
just to reinforce the point you made at the very beginning, we did a study and subsequently published it on sight-threatening corneal ulcers that were admitted for inpatient treatment. And after taking the scrapes and everything else, we then start treatment straight away. And the standard we have is 1 aminoglycoside and 1 cephalosporin intensive treatment. What we found was that those that were culture positive and those that were culture negative, there was no difference in the outcome
Yes.
of their treatment. Equal number failed, equal number succeeded. So it tells you that just getting a positive culture is not the end of everything. You can empirically start and still have a.
Can we show the?
Can I ask you a question too? We often encounter the patient with severe corneal ulcer that all the results were negative, even though with the in vivo microscopy. Do you have any, in your practice, do you normally reduce, like try the antimicrobial one by one and challenging, or you like start all the medication and see the response?
I usually stop all the medication and assess the patient in 24 hours to understand how the clinical picture is.
Even though if it results still negative and then it progress, so you're going to challenging the antimicrobial one by one, not like.
No, I don't think so that you should just keep challenging the by giving empirically. I think non-healing or culture negative corneal ulcer pose a very, very different challenge. And although we are not covering it here, but we have found that in these patients, if you stop drugs and then culture them again after say 48 hours, you are likely to get a good yield. And you will, at times, you will be able to differentiate keratitis medicamentosa from other frank corneal infections.
All right, thank you so much. Do you have any experience with the corneal impression membrane that proposed by the group in the UK that they say that when you stamped the papers on the cornea instead of the scraping, the result is quite similar, but
I don't think so that by just putting impression cytology, you will get enough organism.
thank you so much.
Okay, now the second talk that I'm going to talk about is anti-infective or challenges, and particularly talking about antimicrobial resistance. I'll just briefly cover the AMR for systemic infection and then what is the status of antimicrobial resistance in ocular infection. Does it translate into treatment failure, and how do we handle antimicrobial resistance? And what is the value of fortified antibiotic or a combination of antibiotic? I'll just begin with this case of 50-year-old female who presented to us with the redness and pain of 7 days duration, and local ophthalmologist treated this patient with moxifloxacin and atropine, moxifloxacin being administered every 1 hourly. The patient was not responding to treatment and was referred to us. We did corneal scraping and found gram-positive cocci in pairs and groups, which was identified as Staph aureus, but was found to be resistant to all fluoroquinolone, but susceptible to cefazolin, azithromycin, and chloramphenicol. This is yet another case of 73-year-old female housewife presented with history of 15 days duration and was worsening despite treatment with basifloxacin 0.6%, presented to us with the limbus to limbus infiltrate. Here again, the gram-negative bacilli were seen in the smear, Pseudomonas aeruginosa grew, and the antimicrobial susceptibility showed resistance to fluoroquinolones as well as chloramphenicol and intermediate susceptibility to tobramycin. I think both these cases give you a perspective that antimicrobial resistance on in vitro susceptibility tests is not uncommon even in ocular infections. And this is not a new phenomena. Right from the time the penicillin was discovered, there was a note written by Alexander Fleming where he warned clinicians that a thoughtless person playing with penicillin is morally responsible for death of men who finally succumbed to infection with penicillin-resistant organism. And I hope this evil can be averted. But despite that warning, in those days, as soon as penicillin was approved for clinical use and was found to be effective, there were billboards where they were displayed that, oh, now you have penicillin, everything is honky-dory, we can treat any kind of infection. But this is how the whole spectrum changed, and over a period of time, the penicillin started, or organisms started developing resistance to penicillin, and the situation worsened. This is not just the story of penicillin. Any antibiotic that has been brought for clinical use within few years after its introduction has shown the phenomena whereby the microorganisms develop resistance against those antibiotics. Today, World Health Organization has identified AMR as a major problem because it's present all across world. It is not just a serious public health concern for treatment of malaria, tuberculosis, and HIV. It is also not just a hospital-acquired phenomena, but is increasingly being noticed in the common bacterial infection. And today we have organisms which are resistant to multiple classes of antibiotics. This is not just true for methicillin-resistant Staphylococcus aureus, but a wide variety of Enterobacteriaceae organisms are showing resistance to a wide variety of drugs that are listed here. And there is a rise in number of organisms which are becoming resistant to 3 or more classes of antibiotics. What WHO surveillance studies also found that there is a clear association between the use of antibiotic and antimicrobial resistance. And they also found that the time required for development of resistance is much shorter as compared to the recovery of organisms to develop susceptibility on discontinuation of antibiotics. Today we also know that antimicrobial resistance is because of wide variety of phenomena from its use in poultry, animal husbandry, agriculture, the way waste is discarded into community from the industry that are manufacturing antibiotic and so forth. So why are we so concerned about antimicrobial resistance? I think if you look at the discovery of antibiotic, you will find that many more drugs were brought in the market until at the beginning of this century. But after that, there has not been any new molecule that has been brought in the market which is effective against microorganisms. So there is a innovation gap. And with organisms becoming more and more resistant to antibiotic, there is a fear that we possibly may end up having a situation similar to a pre-antibiotic era where we are not left with any option to treat these cases. So is an AMR a problem in ocular infection? I think let me take you back into the bacterial keratitis study where ofloxacin was compared with a combination of tobramycin and cefazolin, and they found that monotherapy with ofloxacin was as effective as a combination therapy. And therefore, it was approved for widespread use. It was commercially available with proven safety, toxicity, and shelf life. But in 1999, we published a report where we showed that there was a progressive development of resistance in Pseudomonas for ciprofloxacin and ofloxacin. Subsequently, there were many more reports of development of resistance among gram-positive as well as gram-negative organisms against first generation of fluoroquinolones. And it was known that this class of antibiotics are becoming insensitive. We brought out fourth generation fluoroquinolone, that is 8-methoxy 6-fluoroquinolones, And it was thought that they have not only superior activity against first generation fluoroquinolone resistant organism, but because of their dual mechanism of resistance, they are less likely to develop resistance. And in 2002, in our laboratory, we found that yes, these drugs were very effective against Cipro-resistant gram-positive organism, but they were ineffective against Cipro-resistant gram-negative organisms. When we repeated susceptibility in 2010, we found that many of the organisms are now showing resistance to even the fourth generation fluoroquinolone. More recently, we published a study, Asia Cornea Society Infectious Keratitis study, which showed that the fluoroquinolones are increasingly becoming ineffective and against gram-positive as well as gram-negative organisms. There are other studies, AMR surveillance, that have been published and have clearly shown that antimicrobial resistance is a reality even among organisms isolated from ocular infections. But some of the clinicians argue that we are talking about in vitro susceptibility results. And they are based on the serum concentration that is achieved on systemic administration and has no bearing on ocular infection because you are administering drugs directly to the site of infection. You achieve much higher concentration, and therefore there is a high probability of cure even when the infection is caused by drug-resistant microorganisms. We agree that in vitro resistance is a reality, but the two cases that I showed you at the beginning also demonstrate that they translate into in vivo failure of treatment as well. In addition, there are reports that if you use antibiotic indiscriminately or repeatedly in lower than their therapeutic level, your conjunctiva as well as nasopharynx get colonized by drug-resistant organism, clearly indicating that even the ocular or topical administration of drugs can lead to development of resistance among the organisms that are present in our conjunctival cul-de-sac or nasolacrimal duct. So what should be the way forward if we have to handle this kind of challenges? I think way forward is that we should know our enemy and we should become familiar with our weapons. For that, reference laboratories in each geographical area will have to identify important causative organism and determine susceptibility of all of those. And the best parameter for that is to publish list of MIC90 values against important pathogens of ocular infections. And the drug which has the least MIC90 value should be picked up to treat these infections. For example, in this case, the azithromycin has the least MIC90 value, as you can see. Same is clarithromycin, and therefore these drugs should be picked up for the treatment of atypical mycobacteria. In addition, you should use smart strategies. And what I mean by smart strategies, you should achieve concentration which are above mutation prevention concentration. And that is why there is a role for fortified antibiotic. And if you use combination of fortified antibiotic, you not only will be able to eradicate infections or organisms which have developed resistance, but will be able to prevent development of resistance in the organisms. And that is the role of fortified antibiotic till we are able to get newer antibiotic. There are other innovations that are happening which will achieve much higher concentration in corneal tissue on topical administration. To conclude, microbial keratitis not only poses several challenges as far as diagnosis is concerned, we have to also deal with antimicrobial resistance, which is progressively becoming a serious concern, even in ocular infection. And probably we need a multi-pronged approach to address this challenge. Thank you very much for your kind attention. Any question related to the second talk? If not, I'd like to invite my co-instructor, Dr. Amrita Mohanty, to talk about microsporidia.
Good morning, everyone. I shall be talking about a very interesting organism that is microsporidia, which is a small obligate spore-forming intracellular parasite that infect a broad range of vertebrate and invertebrates. It was first described as an interesting parasite as European silkworm disease. Later, in 1973, the first case of microsporidial stromal keratitis was described by Aston. It infects multiple organs, most commonly the GI tract, followed by ocular infections, then respiratory, muscle, kidney, and CNS. So in ocular manifestation, it is most commonly manifest as epithelial keratoconjunctivitis, followed by stromal, rarely endophthalmitis, and scleritis. It occurs worldwide, but has a wider prevalence of 0 to 50%, most commonly in the South and Southeast Asian countries. The route of infection is fecal-oral, whereas the source of ocular infection is not clear, mostly following exposure to the dirty water of ponds, swimming pools, or among rugby players, then followed by contact lens users. Rarely in cases of refractive surgery, it has also been reported. Previously, it was reported to be in an immunocompromised patient, but now there is an emerging ocular infection among immunocompetent patients as well. So regarding the organism, it belonged to the phylum Microspora and kingdom Protista, but now is recalcified as a sister fungi because of molecular and morphological similarities. It has more than 1,300 species belonging to 200 genera, of which 7 are most commonly reported in the ocular infection. Encephalozone cuniculi and hilum has been reported in the keratoconjunctivitis, whereas the vitiform cornea, previously known as Nosemia corneum, has been reported in the stromal keratitis. It has 2 phases. First is infective stage, which is outside the host, and the multiplicative or the sporogony phase occurs inside the host. So coming to the clinical presentation of MSK, which is quite interesting because it ranges from suppurative inflammation, as you can see in the top 2 picture, where you can see multifocal, deep-seated stromal infiltrate with or without an epithelial defect and hypopyon. The second middle 2 picture, you can see there is a monofocal, deep-seated infiltrate, usually associated with an epithelial defect or sometimes perforation and hypopyon as well. And the below 2 pictures are very interesting, where you can see just a quiescent scar, which might be an active microsporidial keratitis, which causes more confusion and is misdiagnosed as HSP keratitis, and rarely fungal keratitis, and some slow-growing atypical bacterial keratitis. The most interesting part is it doesn't have a definitive clinical management. So when you suspect MSK or microsporidial stromal keratitis, when the patient has a long-standing history with a waxing waning course, usually misdiagnosed and treated as HSP or fungal keratitis, do not respond to the standard medical therapy of antibiotic and antifungal, and interestingly, it is also culture negative. It does not grow in our usual culture plate medias, but requires specific cell culture lines. So when you suspect MSK as a clinical diagnosis, as you can see, it can present as grayish-white, fluffy infiltrate, which can be unifocal, multifocal, and diffuse. Sometimes they do present as pigmented capes, which you can see adjoining to the area of keratitis, associated with perforation, sometimes rarely with vascularization, in contrast to the HSV, and sometimes also as a quiescent scarring with minimal edema. So as it is a deep-seated infiltrate, the microbiological diagnosis can be done by a corneal scraping if it is accessible, or a corneal biopsy by raising a triangular or rectangular flap and scraping in the base as well as the flap of the corneal biopsy flap that is raised. Coming to the stains which are used, most commonly used is the 10% KOH potassium hydroxide and 1% calcoflower white stain, where you see a typical hyperfluorescent oval to round structure which gives a starry sky beautiful appearance, or in the gram stain where you can see the stippled appearance because of the location of the vacuole at the end of the spore. Sometimes germination tubules as this tubular structure can be seen in the gram stain as well. And the modified gel Nansen stain, that is 1% acid fast stain, also you can see this round to oblong spots. Our group has reported that KOH along with KOH calcoflower along with Jaden staining to have a sensitivity of 96.7%, followed by gram staining and GEMSA staining. In this picture, you should always keep in mind of the differential of the yeast because they closely resemble, but the size of the spore are small, typically of 2 to 4 micron infecting the humans, and also they are non-budding. Then coming to the molecular diagnosis, our group has reported 16S RNA-based pan-microsporidian PCR, which has specific primer set for encephalizoom species, that is Cuniculi, Hellam, and intestinalis. It has a sensitivity of 83% and specificity of 98% and can act as an adjunct to the corneal smear examination. Similarly, as discussed by Dr. Garg, confocal microscopy can play a pivotal role when it is a deep-seated infection, and also you can follow the course of the treatment. But the only thing is they are very small and difficult to locate in view of the background noise by the inflammatory cells. But as you can see, these are hyperfluorescent dot-like structure usually occurring in clusters. As discussed, it has high inter-observational variation. Availability and cost has to be kept in mind. To have specific identification, TM can be done, where you can see the number of coils which determine the type of species and number of nuclei, and DNA sequencing. Histopathology, this is the HE stain where you can see there is epithelial ulceration and DM is also not intact at few places. And there are numerous spots. This is a magnified picture. You can see the spots along with the inflammatory blue colored are the inflammatory cells which are mixed PMN and lymphocytic cells. This is the Jaden staining where you can see these spots along with the inflammatory cells. So why the management of MSK is difficult? Because it is a chronic long-standing disease with a duration of presentation ranging from months to years. So it acts by evading the host immune response. It resides in the keratocyte for an extended period. Delay in diagnosis can occur because of this non-specific clinical feature, culture negativity, and most commonly misdiagnosed with HSV or fungus, and its initial response to the topical steroid. And also at the last, we do not have any definitive medical treatment, TPK being preferred till now. So although in vitro experiments have found a wide range of susceptibility for this organism, but it does not match with the clinical response. Combination of 0.02% PHMB or chlorhexidine along with oral albendazole has been tried. As you can see in this patient with moderate MSK being recovered in 6 weeks of this therapy. Similarly, there has been several case reports of using topical voriconazole along with oral itraconazole or albendazole. So this is a case series of 5. This is A to F is the initial presentation of 6 size 5 patient where we had treated this with a novel therapy, that is topical fumisolin. The percentage is a little bit lower, that is 0.007%, along with voriconazole and oral albendazole, where we have achieved clinical response with a median of around 9 months of therapy and with no recurrence followed up to a year. Surgical management, as I have said, is the preferred management till now has been reported to have a success rate of 73 to 95% with repeated therapeutic PK as reported by our group and others. So this fourth picture are very interesting because it will be very interesting to know what has happened to this patient. So the first patient is a case of HSV endothelitis where you can see footprint scars, vessels, previous history and treated with oral acyclovir and topical steroid. B and C are suppurative inflammation where the diagnosis was achieved by corneal biopsy and ended up in therapeutic PK. And the fourth one has a moderate like MSK case where we have managed the patient with topical fumigaline and diagnosed by confocal microscopy. So this is an interesting case where the patient has been treated with us for 2 years as HSV keratitis with oral acyclovir and steroid. And it came with a suppurative inflammation where the smear examination revealed microsporidial spores. DALC was done because it was just involving the anterior 2/3 of the stroma. But the patient ended up with multiple graft recurrences, ultimately ended with a large TPK. So therapeutic PK is still now the preferred treatment for this kind of cases. So coming to the microsporidial keratoconjunctivitis, which is very different to that what we have been discussing about the MSK. This is very superficial epithelial keratitis where you can see this multiple coarse raised SPKs round to oval in region with or without fluorescent staining. Most common differential diagnosis for this MKC is adenovirus. Bilateral involvement has been reported in 8 to 32% of cases. Average duration of exposure to dirty water to that of onset is around 2 weeks and mostly reported in tropical regions during the monsoon season. Low et al. Have described according to the location as central, peripheral, diffuse SPKs. Our group have again described a ring-like SPK pattern. Keratic precipitates, typically non-pigmented, following the resolution of the SPKs, that is around 1 to 2 weeks of appearance of the SPK, can be noted. Coming to the differential of the MKC, adenovirus keratoconjunctivitis usually unilateral or bilaterally asymmetric. There are multiple punctate lesion. This is the subepithelial infiltrate you usually see following the adenovirus keratoconjunctivitis, and they leave behind subepithelial scar. And treatment is usually by topical steroid and tacrolimus. Whereas thiogation SPKs are usually occurs in young and middle-aged, are bilateral as asymmetric. They are coarse, slightly raised subepithelial lesions with variable staining, with chronic exacerbation and remission, and respond to topical steroids without any residual scarring. Other clinical presentation of MKC can be limbitis, corneal edema or endothelitis, and nummular keratitis, which require topical immunosuppressants. So regarding the treatment, epithelial debridement along with oral albendazole or itraconazole and topical broad-spectrum antibiotic like fluoroquinolones and antiparasitic medications have been reported in the literature, but our group has showed no difference between the topical BHMB and the lubricants, as well as no difference with the epithelial debridement. And we prefer topical lubricants and symptomatic treatment for this patient. So this is the treatment algorithm published by our group. So MKC does not require microbiological examination always, but in case of any doubt you can do a simple smear examination to detect the microsporidial spores. So usually they respond to the lubricant and clear in 2 weeks. If they develop any scar or persisting SPKs or subepithelial infiltrate, can be treated with a short course of topical immunosuppressant, that is steroid and tacrolimus. And uveitis usually resolves on its own, but in some recalcitrant cases or when the AC cells is more than 1+, you can always give a trial of topical steroid, but after resolution of the active SPKs. Similarly, severe conjunctival congestion, chemosis or limbitis can be also treated with topical steroids. So this is an interesting case where a 26-year male who was previously treated with epithelial keratitis with us came after 2 months with this kind of very atypical ring-shaped stromal lesions with edema and surrounding subepithelial lesion. This is the AIOS2025 which shows the corneal edema and subepithelial scar. This is the other eye which has peripheral subepithelial scars. Interestingly, on scraping it revealed few microsporial spores in the gram stain as well as in the KOH. We did a real-time PCR for adenovirus and pan-microsporidia. PCR was positive and negative for RT-PCR HSV1. So we treated it with broad-spectrum antibiotic because of the epithelial defect we made and topical steroid. So this is the 1-week visit where you can see the edema has significantly reduced and the topical steroid was tapered. This is the subsequent 4-week and 8-week visit, and it had no recurrence for the 1-year follow-up. So mixed infection with adenovirus has been reported previously by our group, having an incidence of 17%, around 17% along with the microsporidia. Then we came up with this series of 20 cases where you can see the interstitial keratitis like picture with disciform or multiple nummular scars or ring form, which completely resolves with topical steroid, which had rapid resolution with it, and the adenovirus was detected in 70% of cases. Thank you. I'm happy to take any questions.
Thank you very much, Amrita. If there are any questions.
Thank you. Thank
Hello,
you.
sir.
Tacrolimus for viral keratitis, how long do you use it and how often? Please.
I'd like to qualify, it's not viral keratitis that we are using. We are using it for nummular. And many times these patients require tacrolimus for almost a year or so, because it has a waxing and waning course. Oops. Just twice a day.
Yeah, just on that point, many of these organisms become, the infection settles, but the immune response picks up. And the immune response then keeps the disease progress. So you're treating that with either cyclosporin or tacrolimus or even steroids. But steroids have a chance of reactivating the infection, which cyclosporin and tacrolimus is less. I just want to make, you emphasize this point. I think we did this study on corneal vascularization, and we found that the commonest cause is herpetic eye disease. So whenever you see any scar, active lesion or chronic lesion which is not vascularized, it's unlikely to be herpetic. And the interesting point we also noted was that the commonest cause for lipid keratopathy is vascularization produced by herpetic disease. So even the vessels are not the same. The vessels from a bacterial infection or from trauma or for virus are different, and most lipid keratopathy comes from virus-induced vessels.
Yeah. Thank you for that interesting point.
So, fumazoline is available in our pharmacy. You can order it, and the percentage that we have used is 0.007%. We have formulated in our pharmacy, but previous reported was a little bit higher percentage of around 2 to 3 milligram per ml. The advantage of using this relatively lower percentage of fumazoline is the stability, but you need to keep it in the refrigerator. So what we do is we give 4 bottles of fumazoline to the patient. One is to be kept at the room temperature, the rest 3 need to be kept in the refrigerator. And they can eventually use it for 3 to 4 weeks. The stability has already been published by like other authors regarding this.
The main thing that you have to keep in mind with the fumazoline is that the average duration of treatment is 9 months.
Right.
It's not going to show you response quickly, and therefore these patients become very nervous over a period of time. What is happening?
And also we have given oral albendazole after our physician clearance, and also our LFT and CBC has to be repeated in every 3 months. So basically, medical management can be tried in mild to moderate cases only, with anterior to mid-stromal infiltrate with minimal AC involvement. Wherever we see frank suppurative inflammation or deep-seated infiltrate or perforation, we prefer therapeutic PK.
No, but it's still, Vinashri, it is the main line of treatment for microsporidial stromal keratitis, even at our center, continues to be full thickness penetrating keratoplasty. So these are cases which have been enrolled for a specific study, and we found that possibly patients who are not willing to undergo therapeutic keratoplasty, or those which are small off the visual axis, you can give a medical a trial with the medical treatment. Okay, thanks very much, and let me move on to the next talk, which is around atypical mycobacteria. I hope. Good. So the objective of this talk will be to share with you our experience with atypical mycobacteria and nocardia, the two acid-fast bacilli that we have seen as causative organism for microbial keratitis, and to give you a perspective of clinical scenario in which you must suspect atypical mycobacteria as causative agent. And I'll begin with this case, and this is my first case of atypical mycobacteria that I saw when I was doing fellowship. So I keep showing this because this was true teacher for me. Was a 25-year-old male who came to us with a history of pain, redness, watering of 6 weeks duration following a corneal foreign body removal. The patient was initially treated with antibiotic by the local physician, showed some response but then deteriorated, and finally after changing antibiotic for 2-3 times, this patient was referred to us. We did corneal scraping and could not identify any organism both on the smear and culture. So we treated at that point of time with ciprofloxacin monotherapy because that was the most common way corneal infections were being treated. Patient showed some response. You can see some scarring, but then I saw in 4 weeks later there was renewed activity at the central edge of the infiltrate. We switched antibiotic to cefazolin and tobramycin. Patient showed some response further, and then this lesion again reappeared, and that made us nervous as to what is happening. Why is this patient not responding to treatment? We reviewed the clinical history and found why was this patient presented to us with 6 weeks history, but still you see the infiltrate is very small. It's a slowly progressive keratitis, unlike many other virulent organisms that cause very active. And then there was a definitive history of foreign body removal. And we went back, reviewed the literature, and found that this is a typical scenario in which acid-fast bacilli are the causative organism. We also saw that there was a waxing and waning course. Patient showed some response, deteriorated, showed some response, deteriorated. We reviewed the corneal scraping and found multiple unstained bacilli. We counter-stained with Ziehl-Neelsen staining and found multiple acid-fast bacilli, and that was published in the journal Cornea at that point of time. Fortunately, we had a confluent growth on blood agar, which was identified as Mycobacterium shilloni. So atypical mycobacteria pose several diagnostic challenges because the clinical picture is not very characteristic. They can present as suppurative keratitis, which is localized, diffuse. They may even appear as a graft infiltrate. So it's very varied clinical picture. Plus, we are not much familiar. That's not the first diagnosis we think about whenever we deal with the keratitis cases. And then, if you do not use a specific stain, it goes unnoticed because of they are very resistant to staining by the typical gram stain. So they are missed often, even in the microbiology. So what we did is that we analyzed the 52 cases of atypical mycobacteria in the year 2016 and found that few characteristic feature of atypical mycobacterial keratitis. The history duration is usually in weeks to months. Many of these patients will come to tertiary center with a very, very long history. Number two, the trauma was the most important predisposing factor, whether it be surgical trauma, which is post-keratoplasty, post-scleral buccal, or post-foreign body removal, or even the metallic foreign bodies. In addition, among the surgical procedure, we found that atypical mycobacteria was seen following cataract surgery, LASIK, keratoplasty, and scleral buccal infection. We also found that many of these patients have a history of not only treatment with antibiotic, but they were given corticosteroid in somewhere during the course of treatment. And the microbiology typically misses these organisms on gram stain unless your microbiologist is tuned to identify these cases. The antibiotic susceptibility was highest for azithromycin and clarithromycin, followed by amikacin. Now, when you treat these infections with amikacin, you will find that they develop some side effects of aminoglycoside toxicity in the form of pseudomembranous conjunctivitis. Another challenge with this infection is that they very slowly respond to therapy and at times require some kind of debulking before they get cured, and therefore we should not hesitate to not undertake them for surgical procedure if it is required. To give you perspective under what circumstances we should suspect atypical mycobacteria, let me take you through this case of 29-year-old male who presented with the history of 1 month duration. There was no history of trauma, no similar episodes in past, no systemic illness, and the clinical picture was a case of stromal keratitis. And most likely diagnosis under this circumstance will be HSV stromal keratitis. When we looked at the medical history, we found the patient was treated with cefazolin, gentamicin every 1 hourly, and despite that, this patient was not responding to medical treatment. So we thought that we are dealing with a case of HSV stromal keratitis and started treatment with prednisolone and oral acyclovir. The patient showed some response. You can see that edema has reduced. You are able to see iris details better. And finally, in about a month time, the edema has almost disappeared. What is your impression? What are we dealing with? Are we right in the treatment that we are offering, or there are any concerns? And I think if you pay attention to this lesion, a very small lesion here became worse and now has completely as if chalky white deposits are present. That made us suspect that we are dealing with something which is not letting this epithelial defect heal. We did corneal scraping and found multiple acid-fast bacilli. So in your clinical practice, anytime you find a patient which is presenting with the history, which is long-standing in weeks and months, where the patient is showing waxing and waning course, if there is a history of trauma or metallic foreign body, it's substantiate, and especially if there has been surgery. And if the patient has been treated with steroid, inflammation subsided, then again, you should suspect atypical mycobacteria. This is yet another patient, was treated as HSV geographical ulcer. We found that this patient showed no organism on the initial corneal scraping. With 5 months history, we suspected strongly atypical mycobacteria and gave a drug holiday to pick up the organism. And slowly, over a period of time, this patient responded very well and got cured on amikacin therapy. Coming to nocardia, this is being an organism which is filamentous acid-fast bacilli isolated from infection everywhere in the eye. Here again, the mean duration of history is usually long, and they present with the classical pinhead-sized lesions arranged in a wreath pattern. But you should also note that at times the clinical picture may resemble fungal keratitis or any suppurative keratitis. Fortunately, the diagnosis is relatively easy because it stains well even with the gram stain or 1% acid fast and grows as a chalky white colonies on chocolate agar. So you are unlikely to miss this organism. And this organism also is very susceptible to amikacin, gentamicin and other aminoglycoside. And the average duration of treatment in these patients is 6 to 8 weeks and respond very well. Only few cases require surgical management. We published a complete review of nocardia keratitis in ophthalmology way back in 2012, and you can refer that as a reference for knowing more about nocardia, not just keratitis, but also scleritis as well as endophthalmitis. To summarize, non-tubercular mycobacteria are rare but important causes of keratitis. They have variable clinical picture, but accidental or surgical trauma with the waxing waning course and a localized infiltrate should give you a high index of suspicion, which will help you establish the diagnosis. Thank you very much for your kind attention, and I'll be happy to take any questions on this. Okay, if not, then I'll invite Amrita to talk about the Pythium. I think this is a pre-recorded lecture of Dr. Bhupesh Bagga again, who could not attend this meeting. So if you can play that lecture.
Distributed geographically, mainly among tropical countries, subtropical and temperate regions. It is, hello everyone, I have no financial enclosure regarding this talk. Pythium insidiosum keratitis is distributed geographically, mainly among tropical countries, subtropical and temperate regions. It is having basically 4 clinical subgroups. The most common is vascular, which is around 59%, followed by ocular, 33%, cutaneous and subcutaneous and disseminated cases. Risk factors of non-ocular pathiosis is thalassemia, hemoglobinopathy syndrome, while ocular pathiosis is more commonly seen in rainy season, associated with farming exposure, direct contact with water resource or use of contact lens. Pythium basically belong to a group called as oomycetes and family Pythiaceae. But if you see the historical facts about this organism, it was first described as fungus in 1880 by Smith et al. Because lack of sporulation was there, it was described as hypomycosis destruens by Bridges et al. Later on, it actually differentiated from fungus as oomycete. But phylogenetically, it resembles more with algae than fungi. So regarding the life cycle of Pythium, the most important part of Pythium is zoospore, actually able to generate in our laboratory with the help of carnation leaves in aquatic media. As you can really observe, there are formation of zoospores from the microsporangia. So it is important to know about Pythium because of different response of these 2 organisms with the use of antifungals. As you can observe here, fungus resolved with the use of antifungals, with the Pythium worsened with the use of antifungals, which are there with Pythium keratitis, is difficulty in making a diagnosis because of closely mimicking fungus clinically as well as microbiologically, and difficulty of treatment because it is non-responding to antifungals. So there are certain investigations, like in microbiology, gram stain, as I previously described, is a broad aseptate ribbon-shaped filament. It takes GMS stain as of the both, but in KOH we can differentiate it from fungus because of aseptations and broad and ribbon-shaped. PAS stain is also able to differentiate between these two organisms because Pythium is not taking stain versus fungus takes stain of PAS. Our group, led by Ruchi Mittal, described a novel diagnostic staining technique made of AIOS2025-IC387 where you can see fungal filaments, Pythium filaments are appearing as a blue color in histopathology specimen. Another way is to differentiate is from quality of growth, whereas Pythium is more of feathery edged, slightly submerged and flat and pressed type of element, while as a fungus is classically described as raised and white cottony color. The feature is the formation of zoospore, which is we can produce in our laboratory with the help of carnation leaves. When we took this growth from solid media to aquatic media, the formation of zoospores as can be observed in these two videos. Another way to diagnose is by help of PCR. Treatment was again a second challenge after making a correct diagnosis because it doesn't respond to antifungals, as has been observed in various studies that existing antifungals are not effective against Pythium infections. As observed here, out of 46 cases, 42 underwent surgery, rhinoplasty, and in that 26 actually recurred back, and the results of those are not that much great. So the conclusion was the treatment of Pythium keratitis is surgical, but 50% of TPKs also had a recurrence after transplant and requiring resurgery. So as can observed in this patient, after successful grafting, taking a large graft also, there was a recurrence of Pythium. Here also it is a very 360-degree recurrence from the host site and finally led to the dissolution of the eye. Our experience 2015 was not different from others, and we observed nearly 90% of cases undergoing transplant for resolution of infection with almost every graft was filled. So difference between the Pythium, why this is in response, lies in the structure of its cell wall because it lacks ergosterol, and we know that antifungals works through use of ergosterol synthesis, stopping the ergosterol synthesis. So why this is happening? The cause of poor response to antifungals in Pythium lies in its peculiar cell wall, which lacks ergosterol, and as we know, antifungals works by stopping ergosterol synthesis. That is the reason Pythium does not respond to antifungals. We did trial of anti-Pythium susceptibility in our lab, where we found that linezolid, minocycline, tetracycline, followed by others, erythromycin, were having susceptibility against Pythium. So based upon that trial, we performed and made a challenging rabbit model of Pythium keratitis. Dr. Savitri Sharma led this trial, and as we can observe here in this video, the rabbit cornea was used for making in vivo model of Pythium, where we injected zoospores intrastomally in the cornea and then treated with the use of these antibiotics. As we can observe here, in linezolid group, there was success of 50%. Erythromycin group, there was success of 33%. Based upon these observations and antifungal susceptibility group, we combined and come out to with this treatment that we'll combine linezolid and erythromycin and give to our patient. And there was again challenge because there is no topical linezolid was available. So we decided to go direct concentration of linezolid as a topical along with erythromycin ointment or drops medications along with oral linezolid or oral erythromycin as a combination. Based upon this experience of in vivo and in vitro antibiotic suitability testing, this is our first patient we managed with a combination of these two antibiotics, and this was a 3.7 to 1.4 millimeters, was smaller infiltrate with a confirmed pythium, and it responded in 1.5 months. So we conducted pilot trial and come out with the treatment in our publication. It is called as leap forward in the treatment of pythium keratitis. And here are some responses. You can observe in the size of 7 to 8 millimeter pythium started responding to the treatment, and even the larger advanced form of pythium keratitis also being managed on medical ground. And this is the typical response which we achieve with the use of medical management. And we come out with what are the signs of resolution, how to differentiate between the worsening and resolution. So clinical signs of resolution starts usually in 10 to 14 days. The median time to resolve with medical treatment is around 3 months. And usually first sign is blunting of edges, the tentacles, the fading of pinhead-like lesions, as it can be observed here. Another classical sign is guttering around the infiltrate. It also appears in many cases that sometimes thinning is more, so we have to apply glue and damage contact lens. So these are the classical signs of resolution as mentioned before. Not only it's improve the medical management, but also improve the surgical management. Cases who didn't respond to medical management and kept on worsening due to advanced stage at the time of presentation. We performed therapeutic keratoplasty, but fortunately none of the case came with a recurrence. So this case underwent therapeutic keratoplasty because of worsening of pythium keratitis. Later on failed graft and underwent DSEC. The outcome is quite nice with a vision of 20/20 restoration. So based upon our experiences gained in last 5 years, we come out with this management algorithm that whenever you have these clinical signs such as tentacles, pinhead lesions, guttering or plaque-like lesion, and patient is on worsening on antifungals, start thinking in line of pythium keratitis. Look carefully grams and KOH smears, culture as well as perform PCR to confirm pythium, the formation of zoospores in aquatic media. After confirmation, start the patient on antibiotics in combination for 10 to 14 days and observe carefully to find the response. Then continue the same treatment if found to be worsening. Then go with therapeutic keratoplasty with extra large margin. If no, continue same treatment and observe carefully with the thinning or posterior lesions. Hello everyone. I have no.
So this is about the pythium, which is almost like fungal looking organism. But now we treat that effectively using linezolid and azithromycin, and very few cases require surgical management. I think with that, at this point of time, I'd like to invite Professor Harminder Dua to give his keynote lecture on corneal. The title of his talk is Dynamics of Corneal Perforation and Corneal Gluing, and we are very fortunate to have him give his talk during our session, which is talking about corneal infection. So thank you very much, and over to you, Professor Dua.
Good morning, and thank you for the opportunity to present my thoughts on corneal gluing. It's a very simple talk, but very useful in day-to-day management, particularly of the conditions we have seen which advance to perforation. Corneal perforations can be traumatic or non-traumatic, and it's the non-traumatic ones that I'm going to be talking about largely, like the ones we saw where there is tissue necrosis, associated with perforation either due to infection or due to immune disease. When you see corneal perforations and sidal positive eyes, you will see sometimes the anterior chamber is deep and formed, and sometimes it is flat or very shallow. And that's what intrigued us, why it's not just the size of the perforation, is there something else? So let's talk about gluing first. So we have two types of gluing. One is a synthetic cyanoacrylate, non-biocompatible, non-biodegradable, and the other is a fibrin glue, which is a biological glue, biocompatible and biodegradable. The way we do cyanoacrylate glue applications, we take a skin biopsy punch, we make a small disc, 2 or 3 millimeters, we cut the end of a swab, put some ointment or gel, and make a hanging drop preparation. So you put the stick on the disc and then put the cyanoacrylate glue, extremely small quantity, and then you bring it on top of the area you're going to glue. The most important point of this area is you have to scrape away and remove all loose tissue, loose epithelium and discharge, otherwise the glue will stick to the epithelium and fall off. So once you've done that, then you get ready, you're poised with the glue. This glue will only polymerize in contact with water. So a bit of leaking aqueous is good. While it's in the air, it will not polymerize, and you just touch it on the area of perforation. The disc helps to spread the glue flat on the area that you want it to spread on, and the disc may stick, then you leave it behind. If it comes off, you take it off, the glue stays behind, and you put a contact lens on it. This is an example of good glue application with very little glue coming outside the disc. This is an example of excessive glue, and sometimes once you put one patch, you test for leak, and if it's leaking at the edge, at one point you put an overlapping patch of glue again. That was what was done here, but there's a lot of excess glue you can see, which then causes more inflammation, and invariably over time this glue causes vascularization. Now, if you have an iris prolapse through the hole, you put cyanoacrylate glue, it's going to stick to the iris. So in the presence of active infection, we invented or innovated this technique called the double drape technique. So we make a small 2 millimeter disc of the plastic, and the plastic is, the drape you use for surgical, over the surgical field, the non-sticky ends. That's the bit you just make a little disc out of that. So you put the disc on the actual perforation, and then come with a larger 3 millimeter disc with the glue, and you put it on top. So the glue doesn't directly contact with the iris, and you don't get permanent iris sticking to the glue and the disc outside. Occasionally you have to do something different when there's a very large leak like this one in the graft host junction. And what happened here was that the infection occurred and the graft host junction slightly dehisced and it was leaking. So again, very important to get rid of all the epithelium, otherwise the glue will stick to the epithelium and will be of no use. So you get rid of all of that, and you come with a drop at the end of a needle, and then you drop the cyanoacrylate glue, let it spread, and you can see it's polymerizing immediately. If you feel there's area uncovered, you can touch it up again, and a large area which is not a defined perforation but a large leak can be managed in this manner. This glue is not without its own complications, because you can have infection persist. Although cyanoacrylate glue is good against some organisms, it will kill and also helps with that, but infection can persist and spread. You will, like I said, invariably get vascularization, some hemorrhage, giant papillary conjunctivitis, and premature dislodgement when you have to put the glue again. Now, just quickly about fibrin glue. This is used quite extensively for various indications as listed over there, but it can also be used to seal perforations, both traumatic and non-traumatic. It starts to set within a minute, so you have plenty of time, particularly if you're doing an amniotic membrane gluing or an autoconjunctival graft gluing. It solidifies in 3 to 5 minutes, achieves most of its strength in 10 minutes, and then by 2 hours it's fully consolidated. By 14 days it will reabsorb, unlike a normal clot, which resolves in about 4 or 5 days, because this has aprotinin in it, and aprotinin is an antifibrinolytic agent, and stop the fibrinolysis from occurring in the commercially available tissue glue. It's very useful if you see this patient had intensive herpetic disease recurring in a graft. The graft had failed, a lot of vascularization. So we repeated the graft, but despite sutures, due to the disparity in the graft-host junction, the host was very thin, it continued to leak. So we put more sutures, it was still leaking. So this is where we first innovated with fibrin glue injected into the anterior chamber in the quadrant of the leak. That fibrin glue is completely harmless in the anterior chamber, but it seals the entire quadrant, entire sector, and stops the leak. And then by the time it is absorbed, it has provided a scaffold over which the cells can grow and seal the leak. If you have large holes like this, sometimes we see that after grafts in thin corneas, they're very difficult to close by suturing. So you can just put glue directly through that hole into that area, and it will not only seal the hole, it'll be in the anterior chamber below, and then over time, like I said, the scaffold provides new keratocytes, fibroblasts to grow and seal the hole. So very useful in that context. This is one hot metallic foreign body, went into the patient's eye. You can see almost touching the iris. And this, because of the heat, the collagen shrinks around it and leaves a hole. That hole will not seal by itself because there is shrinkage of collagen. So we pulled out the foreign body, and then we take this glue, and this glue comes in two components, but you can inject through a 30 gauge needle into the track, and some will go into the anterior chamber, but it will solidify in that track, and then once it sets, it becomes cidal negative, and you put a bandage contact lens and treat with antibiotics. So very useful in a variety of applications. Now, trabeculectomy leaks, the glaucoma surgeons put autologous blood. We inject the fibrin glue into the bleb, and it will stop the leak. It will probably stop the drainage as well for a while, so you might get temporary rise in pressure. So you can treat that with acetazolamide tablets, and then once the glue is absorbed, the bleb starts to function again, but it's very much more useful and almost as good as autologous blood, if not better, but a little more expensive. Now I want to just finish off with this concept, which you may or may not know. The first question I asked, why some anterior chambers are deep and some are shallow. So with this prospective study of non-traumatic corneal perforations, this has been published, although I haven't put the reference there, and we did optical coherence tomography before the application of cyanide acrylate glue, afterwards, and when it had completely healed. The group 1 was where there was a cidal positive with a formed AC, and what we noted was there's a lot of stromal hydration. The cornea is thicker, multiple pockets of fluid appear in the stroma. There are epithelial bullae, and there is an indirect communication between the endothelial part of the perforation and the epithelial part of the perforation. Whereas in the group 2, the AC was shallow or flat, the hydration of the cornea was less, there were no pockets of intrastromal fluid, no epithelial bullae, and there was a direct communication. So this is the diagrammatic representation. So you can see if the perforation is here in the endothelial Descemet's membrane, and over there in the epithelial Bowman's membrane side, the water goes through the lamellae, and then you get accumulation of fluid and it leaks from here. So cidal posit is here, but because of that valvular structure of the stroma and the leak is very slow, and the anterior chamber remains formed. Whereas if there's a direct perforation like that, which could be straight or oblique, there is less hydration of the cornea, no fluid vacuoles are seen, and the anterior chamber becomes flat quite rapidly. And after the cornea is healed, you will see the hydration is less, the vacuoles have resolved, but the glue always casts a dense shadow behind it. And these are some of the examples. You can see there was the perforation was here, and the fluid vacuoles are there, and the external perforation was here. There's a bandage contact lens on the top. If there's a glue application here, you can see below that there's a very dense shadow. The other interesting point is that corneal blood vessels always produce a shadow behind it. We published this as 2 separate papers called the barcode sign of corneal vascularization, so not perforation. So when there are blood vessels and the blood is flowing in the blood vessels, so they're active, everything behind it is a dark shadow. And if the blood vessels are treated and they're not active and they're not circulating, then you don't get that shadow. So it's the blood column rather than the blood vessel wall which produces that shadow. And the point where the shadow starts can tell you the actual depth of the blood vessel, where the blood vessel is located in the cornea. So quite interesting, I don't know what happened there. Quite interesting observations you can make just by looking at that barcode sign. These are some other examples of the shadowing produced by the glue and by the blood vessels. And you can see in the group 1 case, let's see here, you can see the internal it's quite sensitive, this keyboard. You can see the perforation site. This is the direct one where it is straight over here. And there was a very nice example of the indirect one, which I showed you, the perforation from one side to the other. So just basically the point is that why the AC is formed and why it's not formed depends on that valvular structure. So to conclude, anterior chamber OCT is very useful in workup of our patients with different kinds of corneal diseases, and particularly including perforations which occur with corneal infections. Indirect perforations are associated with a formed AC, and it's the valvular nature of the fluid flow in the stroma that allows the anterior chamber to remain formed as it slows down the loss of aqueous. And most of these perforations can be managed with cyanoacrylate or fibrin glue. And with regard to cyanoacrylate glue, it's cheap, it's easy to store, it hardens by polymerization, has much greater strength than fibrin glue, but it is non-biodegradable and it has to be removed at some point in time. It will always induce vascularization if left for a long time, and you need to cover it with a bandage contact lens, otherwise the lid blinks will dislodge it, or you will get a lot of giant papillary conjunctivitis underneath it. And to finish off with fibrin glue, it is more expensive, but one vial of 2 mils can be used. Say if you're doing conjunctival autographs, you can use it for 3 or 4 patients, but if you're using it for infective cases, then unless you aliquot it preoperatively and then use it for 1 patient at a time, you probably don't want to use it an infected case application to another case. It is much more versatile. It is a good alternative to sutures in many of these situations, and it can be safely introduced into the anterior chamber and intrastromally without any long-term effects. It has no tissue reaction, but there's a very minimal chance of anaphylaxis to the apratonin which is in it. Thank you.
Thank you, Professor Dua. And if there are any questions, we are almost at the end of the. If not, I'd like to thank you for attending this course, and I hope you will be able to pick up some of these uncommon organisms such as Microsporidia, Pythium, and atypical mycobacteria. With that, enjoy the rest of the meeting. Thank you very much.